Currents of Public Health webinar series. My name is Brian Greer, and I am the Director of Development for the School of Public Health. The goal of this series is to explore relevant public health topics with members of our community. Today's topic is engaging a refugee community to address COVID-19 knowledge, attitudes, and practices. Our guest is Dr. Ashley Owen-Smith, who is an assistant professor at the School of Public Health at Georgia State. Dr. Owen-Smith is a behavioral scientist with research interests in health disparities, mental health, specifically serious mental health illnesses, trauma and suicide, chronic pain, and complementary and alternative approaches to complex conditions with both mental and physical causes and manifestations. Dr. Owen-Smith's research aims to identify questions that are relevant and important to patients and to prioritize the translation of research findings into clinical practice. Accordingly, she is interested in conducting patient-centered research and utilizing patient-reported outcomes. She works closely with patients, caregivers, clinicians, and other healthcare stakeholders, and is interested in employing qualitative and mixed methods. Today's webinar will be guided by 3 general questions. What are you doing? Why is it important? And how can we get involved? A quick note, if you have a question at any point during our conversation, please feel free to type it into the Q&A box and we will try our best to answer. So let's begin. Dr. Owen-Smith, welcome to the webinar. Please tell us about your research, and let's start with our first 2 questions. What are you doing and why is it so important?
Great, thank you so much, Brian. So as you mentioned, I'm just going to talk today briefly about a project that we're working on as part of the Prevention Research Center at Georgia State University, is specifically related to COVID-19 knowledge, attitudes, and practices. And again, kind of particularly related to the COVID-19 vaccine. So here's just a brief overview of the presentation today. Just going to give a brief background about refugee, immigrant, migrant, REM communities in the context of COVID-19 risk, barriers to vaccine uptake, talk about the aims and methods of our project briefly and the next steps, and have some time for Q&A. So REM communities are particularly vulnerable to COVID-19 for a lot of different reasons, including that they make up disproportionate shares of both essential workers in the fight against the pandemic and those in the industries that are hardest hit by its economic impact. And the Migration Policy Institute estimated that about 6 million refugees or immigrants are working in frontline occupations, such as healthcare, food production, and transportation, and are overrepresented in certain critical occupations where they face increased risk of exposure. And another 6 million refugees or immigrants work in industries such as food or domestic household services that have been economically devastated by the epidemic, making up about 20% of the total workers in those industries. And then job loss in this industry affects certainly not just the individuals in the United States, but also the communities in their home countries that have come to rely on their financial support. So REM communities experience barriers to vaccination as well, even under the best of circumstances, even before COVID-19, including language barriers, historical factors such as, for example, prior experiences with vaccinations or vaccination campaigns in their host countries, cultural factors such as different understandings of disease or disease etiology, lack of consistent access to or understanding about how to navigate our very complicated healthcare system, limited trust, particularly of government entities, especially in recent years where there were immigration policies and practices that created a lot of fear among this population and just generalized fear of being in the system. And then other various vaccination concerns related to effectiveness, safety, necessity, some of the same concerns that many of us have. So I think it's important to note that this is all within a much larger context of misinformation, mistrust, and stigma. So the UN Secretary General talked about the pandemic last year as the pandemic of misinformation, which has really involved a rapid spread of quite a bit inaccurate and even harmful information, particularly related to like home remedies that can, supposedly prevent or cure the disease. Social influences driven by the last few years, especially lots of anti-science or anti-government rhetoric, a weak political leadership, fueling conspiracy theories against public health initiatives, add to the complexity of communicating health information about COVID-19 right now. So our current work with local refugee and immigrant community in Clarkston, Georgia, has really revealed profound mistrust of quite a bit of news outlets, public health agencies, healthcare providers, as well as rampant myths and misinformation about COVID-19. Stigma, one other kind of thing to address about stigma, that we've seen this particularly profound in the refugee, immigrant, migrant communities, in part as a result of some early travel restrictions, kind of blaming the foreign others for disease transmission, is really likely to disproportionately impact vulnerable populations like refugees, both documented and undocumented immigrants. So the aims of our current project, I want to talk briefly about the health education campaigns. So we know from evidence around health education communication is that this communication is really most effective when researchers understand community perceptions and attitudes, they identify communities' trusted sources of information, and implement salient public health messaging that really resonates with a specific population. And we don't really fully understand the dynamics of knowledge, attitudes, and beliefs about COVID-19 in this diverse REM community in Clarkston or nationwide. And we don't really understand yet how to effectively develop and disseminate messagings about the COVID vaccine in particular. So our approach to understanding contextually and culturally appropriate source credibility, content, and delivery before disseminating COVID-19 health messaging, and really involving key stakeholders throughout the process is critical to improving health equity for this community. So the aims of our project are to really better understand knowledge, attitudes, and beliefs in the Clarkston and surrounding areas in the REM communities there, identify the best practices for implementing contextually and culturally appropriate health messaging that explicitly addresses COVID-19 knowledge, attitudes, and beliefs, and really think about how to best disseminate this information to the community. So briefly, Clarkston, for those of you who aren't familiar with it, it's one of the largest refugee resettlement sites in the United States, and certainly has so many assets and resources, but also a lot of challenges. So relatively high unemployment rates, relatively high uninsured rates, and those percent living beneath the poverty line. Lots of challenges related to English proficiency and a lack of access to transportation, affordable housing, healthcare, and education and employment opportunities. So for our project, we are going to be and are in the process of conducting a series of focus groups that last about an hour with approximately 6 to 8 people in each. Each focus group is going to be conducted in the native language of the subpopulation of interest. And they're being conducted by trained facilitators who are from the community and speak that language. The focus groups are going to be recorded and professionally transcribed and translated. And our goal is to conduct 10 focus groups in total. And we have completed the Somali and Nepali groups, and the others hope to be completed over the next 2 weeks. We can come back to this in a little bit, but just kind of wanted to give you an overview of the types of questions that we're going to be asking, or that we are asking participants. We're interested in understanding what stories people are hearing about the vaccine, kind of where it came from, how it works, asking people about what they think in terms of intentions around getting the vaccine, and then exploring, what are people's perceptions related to concerns or worries about the vaccine? What are some of the barriers that people might be experiencing or they hear others are experiencing about getting the vaccine? And what would make people in their community feel safer about getting the vaccine? And then lastly, we want to understand how best to disseminate information. So we'll be asking about who are the best people to share this information? What are the best ways to reach people? So in terms of next steps, as I mentioned, we've completed 2 of the focus groups. The remaining groups will hopefully be completed in the next 2 weeks. So we're going to complete the remaining groups and then analyze the qualitative data and then use that information to then develop and disseminate culturally and linguistically appropriate health messaging about the COVID vaccine, and then evaluate the impact of this messaging. I think, it's important just to underscore that, our overarching goal here is to develop this culturally and linguistically appropriate messaging, really so that members of the community have all of the information that they may need or want to make up their own minds about whether to get the vaccine. I think we don't see it as our job to convince people to get the vaccine, but to make sure that people have the information that they need that addresses their specific concerns so that they can make informed decisions about whether to get the vaccine or not. So I'll just pause there and we can move on to additional questions, Brian.
Yeah, and I appreciate the presentation, and I think I had a question that I got from an attendee prior to the event starting, and I think you just touched on it a little bit, and I'll just read it to you. They asked, how can we provide COVID-19 vaccine information for non-English speaking communities? That's the first part. And then they said they're aware of the Georgia Department of Health website having translation on their website, but not everyone will be aware of that or even know what to look for on the website for that information. And then they said, what are some possible resources that could help these communities? So I don't know if there's just a deeper dive you can go in there.
Yeah, I think, certainly print-based vaccine information is helpful. It needs to be linguistically appropriate, right? So we definitely do need to have translated materials available, but it can't just stop there, right? We can't just translate everything into different languages because we can't really make the assumption that everyone can read in their native language, or that everyone will be able to access that information. So I think we need to use a multimodal approach. So we might need to use social media, TV, print, videos, posters, email, phone, text, face-to-face. These are this is kind of part of the information that we're interested in obtaining through the focus groups, is information about what are the best ways to reach people. We definitely know we can't rely just on print, on translated print information. And I think we also need to make sure that the information that we are disseminating is being done through trusted sources or trusted members of the community. So identifying what and who these resources are really comes from strong community engagement and the inclusion of community voices in leadership and planning. And so that's in part why we have a community advisory board as part of the Prevention Research Center. It's why we are using lay community health workers to help conduct the focus groups, why we are using students who are from the community also to help with both conducting the focus groups in the different languages, as well as helping us design and disseminate the materials when we're able to move on to that next step.
Okay. Well, moving to our final main question, and then we'll get some Q&A from the audience. I'm just curious, how can we in the community concerned about public health and this issue become advocates for your work?
Yeah, so there's certainly lots of ways of getting involved. Of course, if there happen to be any donors on the webinar, getting involved from a financial standpoint and supporting our work is welcome. But I think in terms of others of us who want to get involved, first and foremost, going to the PRC website, prc.gsu.edu, and signing up for our newsletter. That's a great way of getting involved, of learning about our events. We have a calendar on the homepage that shows kind of what we're doing. And so we always encourage people to, attend our events, sign up for the newsletter so you're in the loop about what we're doing. Volunteer with our projects. There are a lot of opportunities to get involved in our research projects and to help with translation. If you're a native speaker of some of the language groups that are a part of the Clarkston community. There are also a number of community partners with whom we work who are doing just incredible work. CDF Action, the Clarkston Community Center, the International Rescue Committee, Refugee Women's Network, FNA Health, or Grace Village are two health centers in the community. They all have volunteer opportunities. And certainly during COVID, these organizations have been stretched very thin with resources. And so I think it's always been that way for nonprofits, but especially now it's an all hands on deck kind of situation. And I know that they would welcome any engagement. So those are just a few ways to get involved.
Thank you. Yeah, thank you. And I can definitely help if anyone's interested in the fundraising component. Side note, happy to have those conversations. We have several good questions coming in from those on the webinar today. The first one is, if you've already done some of the focus groups, what have you learned so far?
Yeah, so we are starting to see some commonalities. So, for example, there are some shared concerns related to kind of how the vaccine works, some concerns about it changing your DNA, some concerns about whether it contains pork products, for example, is halal, so kind of some religious and spiritual concerns, which are certainly not specific to Clarkston. So, there do seem to be some things that we know we need to address in our messaging around the vaccine that I think are some legitimate concerns and barriers that are being expressed. I think what's interesting is that there have been a couple of communities, like we've heard that, for example, some of the Somali and Nepali communities seem to, at least the individuals with whom we've spoken, seem to be have more positive attitudes towards the vaccine than the Amharic communities that we've spoken to. And so, this is just a small qualitative subgroup. So, I certainly can't speak for kind of a broader community, certainly not nationally, but in terms of our community, we are seeing some differences in some subgroups in terms of attitudes and beliefs and intentions to get the vaccine. So I think that's helpful for us to know in terms of kind of what does our messaging need to look like? What are some of the specific concerns that our messaging needs to address? And hopefully through these focus groups, we'll learn a little bit more about preferences for how people want to receive the information. We've also seen some variability around that, like some people have expressed really relying heavily, for example, on WhatsApp, whereas others really prefer to get print information from their doctors. So we're going to use that to tailor our messaging.
And a little bit on the focus group, someone asked, how are the participants chosen for the focus groups?
Yeah, so we're using convenience and snowball sampling. So the individuals who are helping us recruit are all members of the community. So some are actually GSU students from the community, and some are like community health workers who work as part of the Refugee Women's Network in Clarkston. So those are the kind of primary ways that we've been recruiting. And all kind of through word of mouth, convenient snowball sampling methods. So kind of traditional qualitative outreach in many ways. But yeah, those are the primary methods for recruitment.
Just a second ago, you touched on some of the religious views. We do have a question here just saying that there is some misinformation within some in the religious community that has talked about the vaccine being, not a good thing, and that there's just some conspiracy theories around its origin. And the question pretty much is, how do you have any advice on how to approach the vaccine, people interested in the vaccine along with these religious beliefs? Is there any sort of approach that you all have come across that helps with trying to limit some of the misinformation or some of the concerns there from that standpoint?
Yeah, I mean, I think that goes back to identifying, who are the trusted messengers. For me to go to the community, I could certainly try to address some of that misinformation, but what I say may or may not resonate, and it may not be perceived as credible and trustworthy. So, what might be more effective, for example, and we've seen examples of this in prior health communication evidence pre-COVID, is, religious leaders in the community. So maybe imams, from mosques might be in a better position to reach out if the issue is kind of related to a religious or spiritual concern. But even if not, oftentimes religious or spiritual leaders in the community are trusted members of the community and are more likely to have their voices heard and seen as credible, more so than someone from, academia. So I think, that's part of our work, and we're going to be doing a social network analysis that Iris Feinberg is leading along with Rich Rothenberg to look at, really trying to map out, who are these trusted voices in the community. And we know that there are kind of formal roles where that person might be the city mayor, might be someone on the city council who has kind of a formal leadership role in the community. But oftentimes they are informal community members, right? They are the neighbors, the friends, the family members, and identifying who these people are that the community really listens to is going to be so important for disseminating this information.
And then a follow up to that question, I just realized a little bit further. What if, and this might be a difficult question, what if it's the religious leaders who are trusting the community that are presenting the misinformation?
Yeah, I mean, that's a difficult,
yeah.
that's a difficult issue. Yeah, for sure. I mean, I think that, that's where we, would have to, I think, rely on multimodal approaches, that we can't, regardless of, who or what, we can't rely on just one way of reaching people. And so, I think our job is to identify a lot of different ways of getting the information out there and figuring out what are the most effective ways. And I kind of rattled off a long list earlier, but, certainly, different social media outlets. A lot of people in the community use WhatsApp. The Refugee Women's Network, lay community healthcare workers, I think are slowly hoping to get back to more of their face-to-face as opposed to virtual activities where they were going to people's homes. We know that's effective. These are people who are trusted by the community, so that might be something we'll rely on. So I think it takes a lot of different modalities.
Gotcha. We have so many questions and we're running out of time. I'm going to choose a couple more here, and then we'll do our best to try to answer those. If anyone wants to put, I guess, a contact information in the Q&A, we can follow up question if we didn't get to it, and I can maybe get back to you that way, because these are very good questions and we just can't get to all of them. The one question here was about what you were just saying with reaching out to folks. You talked about social media. Do you notice that people are more inclined to use their smartphone technology as opposed to laptops or desktops? And I guess that's kind of thinking about the approach on how you present the material, because it's going to be different from a smartphone than it would be a computer. Do you have any advice there or any thoughts?
Yeah, no, I mean, I don't know that we have good data about that. We have some survey data, smaller scale survey data about kind of to what extent do people in the community have smartphones and use smartphones. And it's pretty high in terms of smartphone use. But that's part of the probing that we're doing in the focus groups right now. So we're hoping to better understand how best to present that information.
I think this is a good one here. From what you have seen so far, are there differences in vaccine perceptions from different age groups? And do different age groups have different concerns about the vaccine?
Yeah, it's a great question. And so we will be looking at that. So we, in the 2 focus groups we actually had a good degree of diversity in terms of age. I think the mean was around 40 something, but we had a couple of younger individuals in their 20s, and we also had a couple of older individuals in their 50s and 60s. So from a qualitative standpoint, we'll be able to look at whether the concerns, barriers, and tensions vary by the demographics of the makeup of the focus group. So, I think the jury's still out on that, but that's something that will definitely be of interest, as I think, how we reach out to people of different ages as well will vary. So, certainly our younger people are more technology savvy than our older members of the community. So we know that our modality of outreach will have to vary by age, certainly.
Gotcha. Well, I want to thank everyone for all the great questions. And like I said, we will try our best to follow up with all of you. I think we've got contact information, and we can get back with those folks. I wanted to end with one final question. I'm just curious for your thoughts, given the changes in or potential changes coming down the road in refugee policies and from the new administration. How will the Clarkson community look, in your opinion, in about 3 to 5 years, and how do you perceive your research being impacted?
Oh yes, I think Clarkson's going to look very differently. So Biden's Citizen Act moves forward. That would provide an 8-year path to citizenship for about 11 million undocumented immigrants living in the United States. So certainly, basically after they pass a background check, they would be allowed to live and work in the United States for 5 years. And then after that, they could apply for a green card and giving them permanent status and become citizens after 3 more years. And then the act would also get rid of restrictions on family-based immigration, making it easier for spouses and children to join their families who are already in the country, and expand worker visas to allow more people from other countries to come to the United States for employment. So I think we're looking probably at an even more diverse community over time if that moves forward, and hopefully less anxiety for residents related to threats of deportation, etc. So I think for our research, I think that means we will have more people to reach. So I think if we're able, and hopefully we will be able to reach them and serve them effectively, I think certainly it will be an opportunity for even greater impact.
That's good. It's good to hear. Well, I want to thank everyone for attending the Currents of Public Health webinar today. And I especially want to thank Dr. Ashley Owen-Smith for her informative presentation. So please save the date for our next webinar on Thursday, March 25th at 12 p.m., featuring several School of Public Health alumni who are currently serving in public health roles at the local and state level. They're going to be discussing their careers and how to advance professionally during a global pandemic. So I think that's going to be a very interesting conversation next month. So be on the lookout for that information. In closing, the School of Public Health at Georgia State University is one of the most diverse schools of public health in the nation. We offer a Bachelor of Science in Public Health, a graduate certificate, a Master of Public Health degree in 5 concentrations, a PhD degree in 4 public health areas of knowledge, and a Doctor of Public Health degree. The faculty and students conduct research in the complex public health challenges facing cities across the globe. Our work is often carried out in partnership with communities, the residents, and community-based organizations committed to health equity. If you'd like more information about our programs or how to support the School of Public Health, our students, please visit publichealth.gsu.edu for more information. And as always, for attending, and please join us for our next webinar. Have a good day.